Good afternoon, everyone. It's absolutely wonderful to be here. My name is Linda Smith. I am the CEO of 50 Plus Skills, and we are hosting a series of conversations. I think this is number 4 in the series on longevity, conversations that we think matter. We've done one on health, we've done one on offboarding older employees. We've done one on the immigration of children and grandchildren and parents left behind. And now we're doing this one on end-of-life care and understanding what that means in a longer world. And then we'll take a break and start up with some more from the end of January. We're doing finance on accumulation and decumulation of our wealth across a longer life. And so it's an absolute delight for me to be here. We're a membership community at 50 Plus. We run a number of these kinds of events every month, newsletters to our members, with just really great resources that they can use. Plus, we have some local communities now that we've started to form this year, and we're finding how important it is to meet face-to-face locally. Social engagement is looking to be one of the great definers of a longer, healthier life. And I just said before everybody joined, it's such a delight for me to have 4 friends on the screen that I can bring together that are experts in this field or who care deeply about this field. And so it really is a pleasure. Thank you, Jane and Mapi, Helena, and Fiona for being our 4 speakers today. The session is being recorded. You will get a copy of it. And we're going to do about 30, maybe 35 minutes of conversation. And then we're going to open up for questions. If you have any questions as the speakers are going through, feel free to put your question in the chat, and we'll manage those when we get to the questions. I prefer to do it this way, especially as there's 4 speakers, because otherwise we just may run out of time near the end. So in a world that often rushes past the quiet, sacred moments of life's final chapter, we pause to ask, what does it mean to care well at the end of life? What does it mean to honor a person's story, not just in their prime, but in their closing pages? This conversation is not just about loss alone. It's about dignity, it's about agency, about compassion, and it's about the kind of care that affirms life, even as we prepare for death. So my first speaker is going to be Jane. Jane is a medical doctor here in the Helderberg. She studied at Wits and has done a number of other diplomas in tropical medicine, HIV management, and a postgrad in palliative care. She has just completed 13 years at the local Helderberg Government Hospital with a focus on HIV and palliative care. She locums at the local Helderberg Hospice and is the secretary of the Practitioners Association of Professions in South Africa, working in palliative care. So that's a very long thing, but you have to use it because the acronym will mean nothing to anyone. So welcome, Jane. It's so lovely to have you here. So can you maybe, as a start, give us a brief introduction on hospice and palliative care?
Thank you, Linda. Thanks very much for inviting me. So there's a couple of definitions of palliative care, and I'm probably going to use most closely or align myself most closely to the World Health Organization definition of palliative care, which says that palliative care is an approach to improving the quality of life of patients and their families facing a life-threatening or life-limiting illness. In other words, an illness that is serious, it's complex, and it is life-limiting. It is done through a multidisciplinary team, and we don't only look at the physical aspects of a patient and family's care, but we look at the psychosocial and the spiritual aspects of the patient. Palliative care can happen and can start alongside curative treatment, And I think what's important to know is that in palliative care, the patient is the leader of the team. We also always like to emphasize that in palliative care, we do not believe in hastening death, but we also do not believe in postponing suffering or postponing death, which we see as being a natural part of life. So that's a broad definition of what palliative care is. It's been a well-recognized medical specialty in many countries for a long time. And we're excited to say that with a lot of hard work, UCT has pushed for palliative care to become a subspecialty, which we are hoping will start in 2026. There are 2 applicants. However, they do need to raise R1 million each to cover their studies.
Ouch.
There's no bursaries or involvement from the government, but it is, has been registered now as a subspecialty, and we hope to have two students starting from next year. This is different from just the year's diploma, which is currently what's on offer through UCT. Hospice is community-based. It's owned by the community. It's for the community, and there are many hospices around this country. They are all NGOs, and they receive, or a lot receive, partial but not complete funding from the government. Hospice is one of the vehicles that can be used and through which palliative care is practiced. And if we look at our local hospice here in the Helderberg region, Helderberg Hospice has a 10-bedded inpatient unit, and it also offers a lot of support to patients living in the community. Not all hospices, however, in this country have an inpatient unit. They all offer slightly different options. Palliative care is broader in that palliative care should be practiced with patients in government hospitals, in private hospitals, by general practitioners, by oncologists. So it's a much broader field, and into that, hospice is one of the vehicles that fit into palliative care and offering palliative care with high standards.
Right, wonderful. How early should palliative care be introduced in the journey of a serious illness, and what barriers still present timely integration?
So it's a very interesting question, and there's a theoretical answer, which is as soon as possible. In the past, there used to be a diagram that showed patients entering curative therapy and curative treatment programs. And when those were no longer efficient, were no longer offering anything, then the patient was switched to palliative care. However, now, because we know the word palliate means to cloak from the Latin word, the ideal is for palliative care to come in alongside curative treatment. And overseas, we see palliative care teams being involved in a patient's journey from the beginning whilst they're receiving chemotherapy or radiotherapy. Unfortunately, all too often, palliative care is called in at the last minute. And we would love, as palliative care practitioners, to see palliative care being included alongside other specialities at a much earlier stage in a patient's illness journey.
Thank you so much. Yeah, I have been involved with a dear friend where the hospice came in really late in the journey, and it could have had a completely different end to the story if there, it hadn't been kind of a crisis moment rather than a part of the journey, which I believe can make it just such a beautiful process. In your experience, how does the end-of-life care impact the emotional well-being of caregivers and medical teams?
So sorry, Linda, I'm just going to go back to what are the barriers to people accessing early palliative care. Firstly, I think we are trying to educate specialities of the need and the expertise of a palliative care team coming in sooner. But then I think for a lot of people, it's almost superstitious that once you say palliate or hospice, that means that you've given up hope, and everyone's scared of patients losing hope. That must mean it's the end. And what is a very interesting thing is that in the palliative journey, a lot of people use metaphorically battle terms. We're fighting this, we're going to beat this, we're going to win. And that can have quite a negative connotation where people feel, well, if I'm not cured, then I wasn't a good soldier, I didn't fight the good fight. So in the palliative care world, we're also trying to move away from using these kind of words and images, which have their own connotations. And so, yeah, the barrier is once you say palliative care or hospice, you've given up hope, that's it. And nothing else will happen, and we can't still explore the curative journey, which isn't actually true.
Thank you. Sorry, I interrupted you.
No
So
problem.
let's talk now about the impact on our caregivers and the medical teams. What in your experience, does this impact them from a stress perspective?
I think we have to recognize right up front that palliative care and dying is complex. It can be messy. We cannot give guarantees always, but we try our best. There is a lot that is scientific when we use particular medications in palliative care that is scientifically being backed up. We often use things that other doctors will say, why are you using an antipsychotic for persistent vomiting? And studies have shown that that is a good drug to use for vomiting. But there's also a lot of soft skills because we're dealing with the psychosocial and we're dealing with the spiritual element. So it is or can be a very stressful time, particularly for families that live in chaos or where there's dysfunctional relationships. Those all come to the fore. And I think we have to acknowledge that the Western world as well, we're scared of dying. We don't talk about it anymore. So it is a difficult time. And I think there is a lot of pressure put on caregivers and families during these times when we don't always know exactly how it's going to plan out. We don't know the minute of death. We don't know how the death exactly is going to look. But having said all of that, there are things that we do know, and there are skills that we do have to make that journey so much more different to someone journeying alone or a caregiver journeying alone with a loved one.
Right, thank you. And what role does community, whether family, faith, or care networks, play in supporting a peaceful end of life experience?
So I think we all need to acknowledge that death is part of life and not to poo-poo, even if it's not something we might join, but death cafes. On a webinar the other day, I heard the speaker saying he was going off to a death dinner that he and some close friends have once a month where they just talk about these hard things. So I think first and foremost, as a community and even as faith-based organizations, we need to be real. We need to acknowledge that death 100% is going to happen to all of us, and it's part of life. I think another big important thing that we are hoping to educate people on and the medical world is the advantage of having an advanced care plan where patients' wishes, goals of care, what's important to them, what matters most, what are they willing to trade off, and what has come to light recently, there's a big move to legalize an advanced care plan, but in doing that, a number of societies have got together and with lawyers, and it's been discovered that in the Constitution, in Section 7, there is a very important bit about the legality of a medical proxy or a substitute decision maker if the patient is no longer able to make decisions for themselves. That then legally binding is the medical proxy's voice in that. So in your advanced care plan, of which there are many available, I tend to use PALPRAC, our own advanced care plan, that there is a medical proxy stipulated and that is signed, and that then becomes a legal document. So I think as communities, we need to be encouraging one another to make sure we have an advanced care plan at any point in our lives, no matter what the age is.
Yeah.
And then listening. We don't listen enough. We negate when people say, I'm worried that I'm not going to be here in 6 months' time. Instead of saying, oh, that's rubbish, don't be so negative. I think as a community and as individuals and in the faith-based organizations, we need to listen and just accept we might not be able to fix it all, that the solution is not easy, but that listening and journeying the whole way might be the most important thing we can do for that patient.
Fabulous. Thank you, Jane. And final question for you is, what language or framing have you found most effective in opening conversations about mortality with patients and family?
So I tend to teach the students what I was taught, a mnemonic called Spikes. So important things are, the S is the setting. You can't have a conversation like this in the corridor or around the bed of a patient when there's people choking or vomiting next door. The setting is really important. So a private setting, phones off, always have tissues available. It's just something so practical you can do, is to offer a family member a tissue should they start crying. So the setting of when you have this important conversation is very important. Then it's important to first establish what the family understands about the illness. Often 70% has been shown of patients and families have no understanding really of the seriousness or what their illness is. And then a tool, and I have many colleagues and other more experienced practitioners to thank, but a tool that Catherine Mannix, a well-known English palliative care doctor and author, has used is the invitation. Would it be okay if we had a chat about what the future might look like? So inviting the person and the family into the conversation. It immediately changes the tone and the meaning and how it goes by saying, would it be okay? Getting permission to talk about it. So that's another very important tool. And then there are phrases. It's a skill. When you do the diploma in palliative medicine, there's a whole section on communication skills, and you are tested live as to how you break bad news and how you have a serious illness conversation. So these are very important skills that you can learn, even if it doesn't come naturally. And that is to say phrases like, I'm hoping that you continue to be able to live as you're living for a long time to come. But I'm worried that with your underlying illness, you might get worse, your symptoms might get worse. And if that were to happen, it's important for me to understand what is important to you. What do I need to know about you going forward that will help me care for you as your palliative care doctor, nursing sister, occupational therapist? So there are phrases that we use, and a common one is, I hope, but I worry. So we balance it off. I hope that things will get better, but I worry that if they don't, do I know enough about you and what's important? And that's why I want to have this conversation. So that's how I approach it, is the setting is very important. Another side note is there's a very well-known African palliative care specialist from Rwanda who wrote a book called The Safari Concept. And he said that in family meetings, he has 20, 30 people will arrive, as opposed to maybe we expect one or two. And he's learned to identify who in the room is the main spokesperson for the family. And he relates different spokesperson to being either the lion, the buffalo, the ostrich. It's quite beautiful how he relates it to African animals. The ostrich buries their head in the sand, the lion, very aggressive, comes at you, roaring. So that's the other thing that's helpful, is to identify who is the spokesperson. Otherwise, you find you're going around talking to too many people, but just try and say who will relate this information correctly to other members who need to know. So those are some of the tools that we use in having a serious illness conversation.
Wonderful. Thank you, Jane, for your years of experience, and we really, really appreciate that. So I'm now going to be talking to Fiona Schager. Fiona and I have been friends for more than 30 years, We found ourselves at Smile Educations, working with early childhood and parenting. But Fiona came into Smile with a nursing qualification. But she's also my go-to person. I have to say, whenever I'm sitting with a challenging situation around someone close to death, or where I want to engage, I will phone her, and you are deeply engaged in having helped me through many of those conversations. And so a little bit later in life, Fiona went back and got a master's in nursing science, community nursing. Um, Loves training, and is currently an e-learning coordinator of nursing contracted to the Association of Palliative Care Centres in South Africa. So wonderful to have you here, Fiona. And
Thank you.
Can you maybe explain what you're doing as a palliative care trainer? Because I'm sure there'll be many people that would be interested.
Thank you. Thank you. And thank you so much. And Jane, I think I've seen you at conference, but I've never met you, but know lots of your colleagues and co-workers, etc., which is fantastic. So, and good to hear that it's ongoing and it's national, that we don't have to know each other. So what do? I do facilitate online at the moment. Used to do face-to-face, but post-COVID, we kind of like went on to e-learning. I do contract to APCC, which I think you spoke about. And so we do the palliative care rollout to not just nurses and enrolled nurses, but also to professionals. And so the CCPN course, which we call it the Certified Palliative Care Course for Nurses and Enrolled Nurses, that's a 9-month course that is associated with a UCT, and so they get certified by UCT. And so it's accredited through them. That has 4 modules that we work through. And those 4 modules are the same as the Introduction to Palliative Care course, which is the one that we also do through UCT, but they get CPD points for that, because that is the professionals, it's doctors, nurses, social workers, any of the allied professions that are wanting to start introducing palliative care into their care teams. And so that's the other one. So I coordinate that one on a different basis. That's a 10-week course. And on that, their CPD points are based on pre and post tests. And it's also based on their role play ability and also care plans.
Wonderful.
Going back to the 9-month course, that's based more on the it's theory, but it's also clinical. So they have to do 60 hours clinical practice in an inpatients unit or a community-based, home-based care setting, somewhere, closest to them. The part of one of the clinical tasks that they have to do is they need to go and visit a funeral parlor. And so that they understand what the patient may ask. If they're asking, what happens to me next, that they have also got a reference to, where this patient is going to. So that's quite a big highlight for patients. And then they do other clinical aspects as well. They go and visit there. So that's kind of like what I do. And as I say, face-to-face is more workshops, but mainly online training now. Okay.
Wonderful. So can you share how the training creates a wider range of people who can create dignity and care for individuals at the end of life?
Yeah, I think, for me, the biggest thing is to be able to get the good news out there, what palliative care is. And I think that is the wider community being, of course, the professionals, everybody within the environment that is doing healthcare. I think that's it. It's not just the nurses. It should also be the caregivers. It should be the administrative staff, the wellness, what would you say, teams, etc., that are there, doctors, oncologists, specialist teams as well. So everybody, and that was according to the a resolution that was passed in 2017, which South Africa Department of Health were part of. And that said that every healthcare provider should be trained in introductory palliative care, just knowing what the introduction is. So I think that's important there. So when we're saying that, it's also about recognizing this family. It's not just the care team that's important. It's also the family and the patient. So getting that news to them as well, getting the news to the youth of today, because we were talking about it the other day. Sometimes there's children in schools that are suffering because their parents or they may be ill, but their learner friends may be ill. And so everybody, if they could also know about what palliative care actually is, that I think that's important as well, that we share that news, or share the information. The information sharing is also unlearning what we've been taught as nurses. As nurses, we were taught to tell. We were taught that, we control the interviewing, etc., or the care plan. Whereas in palliative care, the paradigm shift or the unlearning means that the patient is the center, which Jane was saying. It's patient-centered care. They are the pilot of their own ship. And then the family, so that's important as well, that we are empowering families and patients and care teams as well, that are there. So, yeah, I hope that answered your question.
Sure. And then from your perspective, what does a good death look like? And how does palliative care help make that possible?
Yeah. So for me, a good death is that there has been this journey, and I'm going to now share the slide. I want to go back one. There's it. Sorry, there we go. Okay, so Jane did speak about
it's not up,
Oh, is it not sharing now? Is it there?
No.
No, not sharing yet. Okay.
Now I've just unspotlighted myself. It may be because of that. There we are. It's coming up.
Can you see it? Yeah. From the current. Okay, you got it? It's there?
Yeah.
Can you see it? Yeah. So
yes,
as Jane was saying, is that, yeah, that is our palliative care definition. And so if we are living, sleeping, eating, and passing the message on at all times, that quality of life for the patient, a good death would mean that there's inequality, even if they've got 3 days left, that it's quality, it's not quantity, elongated and suffering, and the families. And so for me here, it's all about empowering the families. Jane spoke about communication. If we are able to communicate from the very beginning, from the time of diagnosis, from the time of the patient coming into a palliative care team, is that the communication is happening between the patient and the family. That they're always empowered, they always know what's happening and what may be happening next. And so especially when it comes to end of life, are they aware of what could possibly happen next? And so that also meaning that we're going to relieve the suffering with early identification, brilliant tools that we use to be able to identify what's happening. And to explain here, a good death or end of life care could also mean that we also recognize that palliative care is active. It's not that there's nothing more that can be done. And so when a patient has perhaps a spinal cord compression, that the outcome could be that they could be paralyzed if we did not assess and be aware of that and communicate and evaluate, etc. And so that we are then compounding the problem. So they may be perhaps end of life, but now they also become paralyzed, which now causes a further burden on the nursing care of this patient because of all the complications of being bedbound, paralyzed, etc. So that's just an example of how it's so important that the communication, the empowerment, etc., is happening. And then, of course, the treatment of pain and other problems, physical, psychosocial, and spiritual. Just to add that the holistic care means that at end of life, it's not just about that physical care of the patient. It's also about the spiritual care. And they say that spirituality, a patient will grow most when it comes to end of life or, just before death. And that means that we also need to recognize respectfully and compassionately, what does the patient want? What is their culture and religion or their spirituality? What is their rite of passage? What can we do and what can't we do when it comes to the end of life of that patient? If we haven't asked and we haven't been aware of it and we haven't communicated, we may do more damage or harm to the patient, which brings us then again onto a good death, meaning that we've acknowledged the autonomy of the patient, or the ethical bioethics of that patient, in that we've allowed them to do it their way. They may refuse treatment, and that's okay, as we've said before. The other thing that when it comes to end-of-life care, I think, is to remember, or when it's a good death, is that they have no guilt themselves, or the loved ones have no guilt, because there has been time to perhaps plan and prepare. Jane spoke about the advanced care plan. That's important, if there is an advanced care plan, so the family know what mom wants, that they can then act on that as well. I always say to friends and etc., there's no dress rehearsal when it comes to death or end of life. You've only got the one chance. There's no way to go back. And so try and do it as best you can in getting advice, getting support. And also the support being that you can stay who you are. If you're the wife, stay the wife and get support in, the healthcare caregivers that can be there to assist, etc., so that you have time, to speak to that loved one there. So, and when you say it's a good death, that there was no unnecessary suffering, because there was an awareness of what was happening, from the family and the patient that's also there, or the loved one. Yeah, I think that
covers it.
It covers it, and the continuity of care. There's no abandonment. Often a patient in a hospital will be sent home because there was nothing more that can be done. While in palliative care, there's no abandonment. You are alive until you die. That's the important part. The next slide that I wanted to just show was just...
if you can just be quick, because it's...
yes. That's just showing the difference. Yeah, take a picture of that.
Sure.
I think, because I think that's brilliant to understand, where we all sit in our journey of terminal care, end of life, and what palliative care is. Finally, conclusion is that Cecily Saunders, who was a nurse, then became a social worker, and then a doctor, she said, you matter because you are you, and you matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. And that's
beautiful
palliative care as we do it. As we try and practice it as best possible. Thank you.
Wonderful. Thank you so much, Fiona. Right, now we're over to the Love Legacy Dignity team, but let me do an introduction first. It's wonderful to have you here, Mappy. Mappy turned 50 a few days ago, and so I welcomed her into the 50 Plus Club. She is the co-founder of Love Legacy Dignity and Mindset Content, also the editor-in-chief of Newsroom Africa. So we're delighted to have you in the week of G20 with us, and not in your new studio managing the world. Mappy's mom's journey and specific wishes caused quite some conflict for her during that phase of her life that got her interested in this whole process of the end of life. And she is a grief counselor and writes fabulous articles with Helena on News 24 around these subjects. Helena Dolnay, also co-founder of Love Legacy Dignity and Grey Matters, where she does leadership and development coaching. Helena has written a book called Before, Forever After, When Questions About Living Meet Questions About Dying. After her husband, Joe Slovo's death, and he was sick for 4 years, she realized that there were many conversations that did not happen. And so this work with Love Legacy Dignity creates public evaluation, advocacy work. She's also a hospice counselor, end-of-life guide, and certified grief counselor. So Mappy, we're going to start with you. Am I right? Share with us what Love Legacy Dignity is. And I have to say, I have done their course and I absolutely loved and recommend it. So go for it, Mappy.
Thank you very much, Linda, and good afternoon to everyone joining us today. As Linda indicated in her brief introduction, really Helena and I were brought together by different experiences about the issues of life and death. The gift that my mother gave me was the clarity and a clear direction as to how she wanted the end of life to be, including details planned for her funeral. And her, on the other side, she was startled by the kind of conversation that didn't take place with her ex-husband, Joe Slovo, her late husband, Joe Slovo. So the why of love, legacy, and dignity is that we suffer when loved ones died, but we suffer even more when certain conversation didn't happen. And the whole idea of love, legacy, dignity is to try and change that. How we do that is we've created a love enhancing framework which engage with our mortality through a series of workshops that we do, 5 days, 2 hours for a workshop that is online. We try to create conversation and activities that are provoking, that will help you to start your journey in intersection with questions about dying and how you want to finish. We do not necessarily see this conversation being about just the end of life, but it is about living by design to finish strong. The whole idea is we know as I'm here, there's often this thought that we're going to die a slow death, we will need palliative care, but our mortality knows no boundaries. You can see me today and you can wake up and hear news that I'm no longer around. So we want people to be at peace should they not make it at home in the evening, that their loved ones won't be trust in administrative nightmare or conflict situation because conversation didn't take place. And in the three words, love, legacy, dignity, the love is we really try and help our participant to be at peace with the state of their relationship. We do reflective work, looking back and taking stock of what is it that we're doing that is giving us the return and is giving us the fulfillment that we want. And we will look forward at what is it that we're doing now that will shape our life and shape how we finish. And legacy, it's beyond the traditional matters of money and property. We want to make sure that you create a legacy, just like my mother, where you leave your affairs in order with no complex emotional, administrative detractors for loved ones to clear up once you have left. And then in terms of dignity is, have you made it clear in terms of your life choices for your end of life and your posthumous wishes? In doing so, we often tell our participants that they secure the dignity for those that they leave behind, but also preempt any conflict that might follow. That's really, in a nutshell, what love, legacy, dignity is about. So love affirming a conversation about our mortality and our contribution into making sure that people do live by design in order to finish strong, and that this conversation about how we want to finish are not necessarily seen as the end of life conversation, but as a conversation that informs how we live now.
Wonderful. Thank you, Mapi. So Helena, who should do this course and why? I have to say, for me, it really was a brilliant course, but tell me about who is your audience?
I would say anybody who is over the age of 18. If I had a dream, it would be the inspiration that I saw in La Crosse, Wisconsin, where a group of hospitals and a leader, a bioethicist, in 1985 watched families in a kidney dialysis unit falling apart as they were having to make end-of-life decisions about stopping treatment or not. And the Lutheran Federation of Hospitals in that area of Wisconsin started a project your first conversation begins when you're 18, so you are responsible for the decision making on your life. Should you be in a car crash or whatever, and you definitely need a medical, a healthcare proxy to make decisions if you're unconscious. They have another conversation built in when you get a chronic condition, and they have another conversation built into their health system when your condition deteriorates or you get a terminal diagnosis. The amazing thing about this is that it normalizes conversations about mortality. And that's what the first speaker, Jane Cunningham, was saying, is that people don't want to speak. So I think that is the passion, is that Mapi and I are lay people. Yes, we've done courses, etc., but our audience is lay people. And can we support people to have conversations in their family so that you have a shared understanding when decisions have to be made, and you have an understanding that you have to build relationships with your medical practitioners. The wonderful thing about the US case study, which is our inspiration, is that end-of-life care costs go down because people are clear about what they want and what they don't want. So there's a lot of people, and Mapi included, her family exhausted their family savings in the last year of her mother's life with supportive treatments, hoping for miracles to happen. And when people have done the hard yards of conversations earlier, they have courage, information, and clarity to make tough decisions. The other thing is that in the Wisconsin example, people actually live longer. And I think it's because they are more at ease that they've had those tough conversations. And so when those difficult moments happen, the hard work has already been done in the years before. So for everybody, I mean, I walk into an MBA class at Henley Business School and they wonder why they're doing this life coach, death coach class on a Saturday morning. And I ask, how many people know people of their own age who have already died? And there's never a hand that's not up. So everyone should do this.
Yeah. And I think, this is why I wanted you on as well, is because death comes suddenly for many. It's not that opportunity. And for both my mother and father, it was a phone call of the suddenness. And so whether your life is organized or not organized in that case can make a huge difference to what happens to the people around that scenario as they're grieving, in having to deal with other things that could have made that so much easier. So from a cultural, spiritual, or personal value shaping the end of life, how can care teams honor these differences?
So in my lived experience and network of friends and stories that I've gathered over decades, the spirituality is really important. I've known atheists reach for their prayer books at the end of their lives, and their partners have teased them and said, "Are you cramming for finals?" So I think knowing the spiritual needs and making that possibility, would you like a spiritual advisor to be visiting or to, I think it's difficult for care teams. I mean, people always say they prefer to die at home. The stats show that people say 80% of people say they would rather die at home, but actually 80% of people die in hospital. And so I think it's a tall order for medical care practitioners. I come from a nursing family and women of herbalists. It's a tall order for a medical team to be supporting the psychosocial as well. So the clarity within families of what is the spiritual preferences of the person and what support is important to them is really important. And it will be different culturally.
Yeah, absolutely. Last question for you, Mapi. How do we move beyond the narrative of decline to one of purpose, legacy, and closure in aging and dying?
I think one of the first session that we do when we take our participant through this journey is a session that look at the now, at how are you living now in order to finish strong. We don't necessarily make everything about the conversation for the future should you decline. It's a conversation of all these life choices. What matters to you most? What do you need to have in place? Who needs to know what that you do now so that you live your life at ease, knowing should anything happen to you, whether it's through slow death, through illness, people will know what matters to you. People will know what you have in place, and all the people who need to know will know what needs to happen. I think the most important part is to make this as part of living legacy. That's why we encourage people, young people. We often, it's very strange when we start a conversation with young parents who have not thought about guardianship because they associate that with the decline and the end of life, where we all know that death can be so sudden and it can happen. A lot of people in this country died by on the roads, and they are, have issues with heart attacks. So the whole push for how we frame the conversation and how we frame the cause, it's framed about your daily choices. It's not necessarily only about your end of life. End of life is the knowledge that our life would end, but daily is to live with intention. What you put in your body, how you keep your spirituality, how you look after your well-being. That is about it now. It's not necessarily about your decline. It's the journey to whatever the end that whoever you believe God is has in store for you.
Thank you. Thanks so much, Mapi and Helena. And I am now going to take us back to the gallery view so that we can get some questions answered. So let me just unspotlight you. Gallery view, there we are. Right. Are there any questions, Eddie, in the chat box that have come up that you think are relevant to ask right now? Or
Yeah,
anybody who have a question?
Yeah, Lena had a question about, do you have a standard assessment for patients for end of life in palliative care? I think that was for Jane. Unfortunately, I had to restart my laptop, so I missed some of the earlier chats. There was one
So let me look
regarding the
here.
cost.
Yeah.
Hi, yes, sorry, I just can't start my video again. I think, Eddie, you've disabled it, but I can talk without the video. Let me just try once. Stop by the host. Okay.
Should start now, Jane. I think it was me, actually. Sorry, I was trying to multitask and I wasn't very good. Okay, just speak.
Unknown caller.
Jane, can you answer? Not sure what's happened.
Where is Jane? Is she there? She is there, yeah.
Okay. What was the question again? Sorry, I got sidetracked there.
If there are any standard...
What's the question? Maybe if I can, Linda. The question was, are there any standard assessments that get completed? Because I'm interested in terms of how palliative care interfaces with healthcare providers, but also for the funders as well. And is there a standard process that is followed in assessment in terms of assessing where the person is in terms of their journey and which stages of palliative care are they at? So that was my thinking around that question. Thanks, Eddie.
If Jane can't answer, perhaps I can assist there.
Go for it, Fiona.
Yeah, so there is a standard a tool, a best practice gold standard called the SPIC tool, which came from the UK, but it has been modernized or adjusted to South Africa. So it's the SPIC tool South Africa. But if you want, we can share that as well. And it gives you the kind of like different aspects of the different diseases within South Africa, including burns victims, the elderly, etc., as well as all the other chronic illnesses, that are there. Yeah. Does that help?
That'd be very useful, Fiona.
Yeah.
Thank you.
Yeah.
And if you can share that through the group, I would appreciate it.
Yeah.
Okay.
Yeah.
Can I please ask that if anybody who has put a question in the chat can rather put the camera on, put your hand up, and you can do that from the bottom under the react button and use the hand, because that brings you to the top of the screen. It'll make it easier for me to know who is wanting to engage or ask a specific question. I'm so sorry about Jane.
I don't know what happened.
Yeah. Samantha, if you can just take yourself off mute. You're on mute.
Sorry, my question was about costs. So the friend that I have he's got stage 4 cancer. He did not have a lot of money saved up. So I'm interested in what are the costs involved with hospice.
Fiona?
Yeah. So hospices are all NGOs. So they're not funded by Department of Health. Some of them do get some funding. And so therefore, because they're NGOs, they do rely a lot on public assistance. However, they do, Jane's coming back in, they do not turn any patient away. So the patients that are paying, that have got medical aids, can often cover, the hospice care. So what you need to do is go onto the APCC website and go and look there. They'll say, find a hospice, and by region, you can have a look and see, which hospices are in your area.
I'm curious, are hospices, like my view from the outside, knowing nothing about this, are they normally really busy? Is there like a waiting list? Are they oversubscribed? That's my outside view.
Yeah. Can I answer that? Or maybe is Jane back? Maybe she wants to answer that.
So sorry, I don't know why we lost connection. So firstly, I think
you're frozen, Jane.
Yeah. But I
Fiona,
continue there.
Yeah.
So hospices, yes, because they are NGOs, they are under-resourced always, because funding is a huge issue. However, their standards are absolutely impeccable. They are what would you say? Their accreditation is, if they are APCC accredited, it means that they have to go through accreditation. And so therefore that's important. So don't just go to any hospice, you go to the ones that are on the APCC website, which have the standards that have been approved. So that was the one thing.
And am I right that it could also be a hospice bringing the services to your home?
Yes. Yeah. So in order to register for a hospice, what you have to have is often they want the patient to agree to it, first of all. It's no good the family pushing it unless the patient is happy about it. But that's conversations, it's communication. And then the second thing was that you need to have a referring GP, so that so that there is what would you call it, the aspect of the reason why that patient is being referred. And then there is a first assessment that is done by the nurse or the the hospice doctor. I don't know if you want to, Jane, I think you're back online.
Oh, I'm so sorry. This hasn't ever happened before. Yeah. So a hospice director from another province saying that they found it really difficult going and seeing patients, or admitting patients where it was said that there was no money, only to find that everyone in the household had been for the latest haircut, the latest highlights, etc. So some hospices, and she described a family that had absolutely nothing, from a poor community. It took them 3 hours to walk to the hospice on foot, pushing their father in a wheelchair, and they gave 10 Rand at the end when their father died, and how they didn't give that 10 Rand back. They took that 10 Rand because it meant something to the family, And so
Yeah.
Shame,
Shame.
Jane's. Yeah.
You really are struggling with signal, Jane. And I think the
Yeah.
other thing just to be aware of is that for many medical aids now, there is a end of life care
Yes,
fee for 6 weeks or something.
that's right.
So again, Fiona, you would
Yeah.
probably know what it must be very similar to the hospice, the doctor or whoever is.
That's
is
it. Yes, yeah. So they can have hospice care and it can be covered by medical aids. And that is sustaining a lot of hospices because, you know, they're having the patients that do come, but some of them don't have any with any medical aids. And so again, that's when they are relying totally on, what would you, donations. Remember also hospices also rely heavily on donations from patients that have perhaps passed away. They bequeath certain, you know, furniture, etc., which then goes into secondhand shops. That is what's funding non-paying patients as well. But they do, you know, there is conversations around it. And as Jane was saying, that 10 Rand gave them dignity, the family, that, you know, they paid something rather than nothing. Or they can volunteer. The bread and butter of any hospice is volunteers within that community. You know, they come and help with a bookshop, or they come and help with perhaps catering, you know, fundraising events, etc. So that also works so well, you know, that they can. So yeah, that was
very helpful.
yeah,
Thank you.
yeah, great. Good luck with your friend.
I'm so
Another
sorry, but it
question from
is
Dave
1:30 and I'm going to bring a hard close. What I am going to try and do is a lot of the questions that are in the chat, or even if you have something, you're welcome when you get my email to send me a note, and I will try and ask one of the four to bring some answers that we can then pass on to you. Helena, I'd like you to just talk quickly about your next course so that people know when it is, and I will also put your details in the letter. So if you can just take yourself off mute to say when that will be.
Oh, she's on mute.
Yeah.
Yeah. There you are.
It is March, and through experimentation, we have slowed down the course. We used to do back-to sessions compressed together. We realized that we're asking people to do 2 hours a week for 5 consecutive weeks, and there is work. We have 37 resource documents which we offer, so there's quite a lot of work to do in between. But we're hoping if people do that, they will be living very, very well, and they will be very well prepared for the end of life. The next course is March
Wonderful.
2026. There are 5 Tuesdays in that March.
And I know that you encourage couples to do the course. I did it with a friend whose mom was in her 90s, and because it was lovely in the in-between time to have conversations with someone. And that lady died last week. She lasted for another 4 years, and it's been a very tough journey for my friend, but it was wonderful to be able to have those conversations. So doing it as a couple is definitely first prize. So thank you, Jane. Helena, yeah, you wanted to say something?
Just mothers, daughters, fathers, sons, siblings whose elderly parents are dying. And we've had wonderful outcomes where people have then convened family discussions.
Yeah, wonderful. So thank you, Fiona. Helena, Mappy, I see has gone back to the newsroom. And Jane, I really appreciate your time, your dedication to this industry and to us as humans. It's such an important part. Your book, Helena, Being Mortal, again, a book I think everybody should read. But thank you, everybody. I really appreciate you being here and sticking around to the end, and look out for your email. Thank you so much, everyone.
Thanks. Thank you. Thanks for having us.
Thanks
Bye.
so much.
Thanks, everybody.
Cheers.
Most insightful.